All right, guys, we're back with the trauma. We're doing section chapter 3. This is the second part of this series, and we're talking about the stages of shock. And we kind of went over the classifications of shock, so this is kind of related. So compensated is your stage 1, stage 2, decompensated stage 3, irreversible stage 4. Really important to remember those, okay? And these are a little bit easier to remember, okay? But again, your compensated shock, you get pulse rate increases, pulse strength is going to start to decrease. They'll get, because skin becomes a little bit cool and clammy, they become anxious. But then they get into the decompensated, they lose consciousness, respiration slow or cease, and the blood pressure drops precipitously. Remember, in our pediatric patients, the difference between compensated decompensation shock is blood pressure. Newsflash for the adults, it's the same way. Now, irreversible shock, it starts affecting the body's cells, where irreversible damage happens. The cells die, the tissue begins to dysfunction, the organs dysfunction, and the patient ends up dying. Okay, so again, the types of shock that we deal with in trauma is hypovolemic, cardiogenic, and remember that hemorrhagic is kind of a subset of hypovolemic, low volume. Cardiogenic, pump failure. Neurogenic, nerve control lost. Anaphylactic, that has to do with the blood vessels dilating and not being able to get air in. And then your septic is due to some sort of organism that's causing infection in the body. Okay, hypovolemic shock, everybody should be good with these. Again, they've lost fluids. This can be fluids as blood, as well as, let's say, they've extensively vomited, or in the case of a burn, they lose blood by it seeping through the fluid, the plasma seeping through the skin. Now, your cardiogenic shock, again, that's where your pump is inefficient. And by the way, that's an 80% mortality rate. Now, we have a few things that we can do with that. Neurogenic shock, it usually is because the vessels get bigger because you lose the control. It's called warm shock, again, because usually the skin is warm and pink. And again, they usually don't, they'll be cool, they'll be kind of clammy. But not really, again, they don't have the traditional shock signs, okay? And again, this is kind of a relative hypovolemia in these guys. When there's anaphylaxis, there's a foreign body that causes massive histamine release. Again, displaces, kind of that same way with the neurogenic shock. It's a distributive shock. Same thing with your septic shocks. Again, these guys, it causes the blood vessels to get big. They start to leaks fluid into the interstitial spaces. So how do I handle a patient that's got a hemorrhage or shock? Okay, so again, same thing. We keep check out your scene hazards. Make sure whatever it was isn't going to affect you. Make sure your people are safe, bystanders are safe, patient's going to be safe. Again, keep the hemorrhage and shock patient warm. Okay, evaluate for the mechanism of injury. Determine the time lapse, and again, important to determine the amount of blood loss. Now, the good news is we usually overestimate blood loss. And I'm not saying that's necessarily a bad thing. But again, practice good assessment, identify and locate all possible patients, and then make sure that you maintain the scene safety and scene oversight. There really should be somebody separate from patient care doing scene oversight, okay? Again, primary survey, again, determine where that patient is, their mentation, determine if there's any life-threatening bleeding going on. If we do not have a pulse, CAB, again, start CPR. Remember that if we're doing CPR on a trauma patient, usually the outcome is very poor. Again, airway and breathing, and again, oxygenation. Make sure you got plenty of oxygen going to this patient, okay? If the airway cannot be maintained, ET tube or a different airway or extraglottic airways, look out for the respiratory effort, your chest excursions, and your waveform capnography is a beautiful, wonderful tool here. We can tell how well they're metabolizing, how well they're actually doing at the cell level, okay? So, again, our CUPS acronym is critical, unstable, potentially unstable, or stable. You might see that in the future. Again, rapid care, again, assess, fix airway problems, fix massive bleeding problems, okay? So, make sure that you do that, all right? So, again, the secondary exam goes the same way with these guys, okay? But as you find major bleeding, not little bits of bleeding, but significant life-threatening bleeding, you have to stop and treat that when you find it, okay? Now, That usually means a tourniquet or some sort of holding the pressure, having somebody else hold the pressure on a belly wound or a chest wound or something, or a neck wound of that case. Remember, if you do have neck wounds, by the way, we keep those covered. We don't want an air embolism coming in there. Focus on the exam area. Again, to get your baseline vital signs of this secondary exam. Search for evidence of internal hemorrhage. Guys, don't miss the airway or breathing problem because you got a gruesome injury, okay? Make sure you got good airway, good breathing, and not life-threatening hemorrhage. Bleeding in the abdomen, bleeding into the chest, bleeding into the pelvis. All of those things life-threatening. The guy with a degloving injury, not so much, okay? Yeah, it looks gruesome, but it's not the life-threatening injury part of it, okay? By the way, if you're not sure whether a patient is or isn't in shock, you can do orthostatics. And I know that you guys have seen this in the ER. So, again, if you think that they're low on volume, have them lay down, have them sit up, check their blood pressure, see if their pulse rate goes up. If it goes from after the laying to sitting and then sitting to standing, then if you've got a significant drop in blood pressure, 10 millimeters of mercury, yeah, there's probably a good sign that they're in shock and that they're probably going to need that. A tilt test determines the blood or fluid loss. The body's reduced stability. That's what we're basically doing by doing the orthostatics, okay? Perform only on patients that you don't already display signs and symptoms of shock. Kind of a no-brainer, but we want to repeat that and make sure that you understand it. Now, again, take a look at their history. Okay, make sure that weakness, thirst, nausea, all of these can be signs of shock, and any type of pre-existing medical condition that might be throwing us off, okay? Lots of vomiting. They're taking blood thinners. Oh, yeah, I've had dark tarry stools for 3 weeks. Okay. Now, again, head-to-toe assessment to check for additional signs of injury. Again, every 5 minutes for the critical or unstable or potentially unstable. And if they're a stable one, they get 15 minutes vital signs. And then reassess the mental status, airway, breathing, and circulation when you do that. Look for the trends in the vital signs with your shock patient, okay? Can't stress that one enough. Look for the trends. Is the blood pressure going down? Is the heart rate going up? Is the respiratory rate going up? Okay, all these things. Remember, your respiratory tract is going to be your respiration's going up. Signs of acidosis, trying to get rid of excess carbon dioxide. All of these things play a factor in that. So how do we control bleeding? Again, direct pressure. Again, that's usually the biggest one. Again, if you've got a head wound or an open skull fracture, you don't want to place pressure directly on that but again, you want to make sure that you keep it pressure there, but not pushing in. Okay. Serious bleeding around the eye orbits. Again, you can place pressure directly on the globe of the eye. Again, avoid pressure on the tracheal larynx or airway structures. Can cause major problems there. To the side of them is just fine, guys. Hemorrhage control, again, limb splinting or pneumatic splints actually work pretty good. The local protocol for hemorrhage management is, again, elevation. We use pressure points, guys. All you're doing is you're slowing the flow of blood. But here's the deal. The second that you release that, the pressure is going to go back. It's probably going to destroy whatever clot that's been formed. So if you start using the pressure point, you're going to be using it for a while. Again, if direct pressure doesn't do it, again, consider elevation. If that doesn't work, again, tourniquets to the extremities can be just fine. No, we do not tie a tourniquet on the neck. Thank you. All right. Now, again, in the inside, again, apply firm pressure to that point. And again, the biggest thing is if you got an uncontrolled hemorrhage, you need to get them to a surgeon. It's a surgical emergency at that point. Topical hemostatic agents. This is your quick clots. Oh, yeah, they actually work very well. Dust or dry powder form, or some of them have it in the bandage. Okay? They work really good. Sometimes it's just you sprinkle it in there, you hold it 5-10 minutes, and then boom, look at that, it stopped bleeding. Tourniquets should be your last resort. Again, make sure that you mark your tourniquet with that. And again, guys, don't be afraid of a tourniquet. Tourniquets are okay to use, okay? Battlefield medicine has proved that it works just fine and without significant issues, okay? Now, if we got head injuries, again, just remember if you got hemorrhage with a skull fracture, yeah, that kind of makes things, you might get blood from the ears or nose. We don't try to stop those up. We actually let them bleed, and the reason is because we don't want pressure being built up on those, okay? We talked about all these stuff right there. We talked about this already. We talked about the neck wounds. Guys, the biggest thing with a neck wound, cover it up with an occlusive dressing because we don't want air getting in there. Do not employ the circumferential bandage to create direct pressure, by the way, especially on a neck wound. Dumb as that sounds, you're going to get people that do it. You're going to have to probably hold it until you get to the trauma center. Okay? Again, digital pressure, guys, usually most of the time, watch out for your airway structures on those. Specific wounds, again, if they got gaping wounds, bleeding from multiple sites, usually you're going to need a lot of direct pressure. May even require 2 hands in order to maintain that. Okay? Again, consider your rapid transport. When in doubt, transport. I can't stress that enough. And remember, usually if the bleeding is uncontrolled, it's going to be a surgical emergency in order to repair it. Okay? Especially in the case of trauma. Now, where do we want their blood pressure to be? Just enough. Again, and I get this question asked a lot. You want your O2 sat at least 96%. 94 to 99 is just fine there, guys. Again, if you can't maintain an airway, do you consider RSI? A little bit extreme, but yes, you can. But again, your airway and breathing management, again, that's your first stage of caring for shock, okay? If they're moving air ineffectively, positive pressure ventilations, and again, if you can improve the saturations, don't forget about the CPAP. If they've got chest trauma, remember CPAP is contraindicated because, again, you can bluff a lung. If they got tension pneumothorax, again, confirm it and then provide a pleural decompression. That's kind of, again, that's an obstructive shock. So, again, it's actually stopping the heart from pumping. Again, hemorrhage control. We want to stop the little red blood cells from going out, okay? And then fluid replacement. Now, boy, has this one hit the controversy circuit major. And it should, by the way, because if we continue to add fluid without the oxygen carrying capacity, yeah, they're going to die. Okay? So the key thing is number one, hold on to the red blood cells. And number two, we use isotonic crystalloids to keep the blood pressure up. But just understand it doesn't replace the blood. Okay? So therefore, you only got a certain number of red blood cells carrying oxygen. If they're not carrying enough oxygen, they're still going to be in shock, okay? They do make their testing agents. They still, if you ever invent the agent that carries oxygen through the bloodstream that can work on a patient, you're going to be a rich individual, okay? So, again, isotonic fluid administration. Again, colloids can also be used. But the biggest thing is the isotonic fluids that we carry, normal saline lactated ringers, okay? Just remember, it's not blood, okay? It's not blood. I can't stress that. It will help. It's a temporary fix. And by the way, the surgeons kind of hate it, actually, because it thins out the blood and it interrupts their capacity. They really would prefer blood product in there. Well, my simple statement is, well, let's start carrying blood. But there's all kinds of issues with carrying blood. All right? So, again, there's 3 ways in which we give it: rapid, transient, or minimal or no response. Usually if it's a mild hypovolemia, very minimal blood loss, you're going to get good results from giving a crystalloids. You might get a temporary upping in blood pressure, but if they're still bleeding, it's going to go back down. Or worse yet, you're going to give them fluids and their pressure stays in the toilet, okay? Large bore, again, saline lock, preferably no saline lock on there, guys, because, again, it's just like an appliance in a fire hose. It does restrict fluid. So if you can detach it straight in and let it flow, okay? Less things that it has to go through, the better, okay? And, again, it's the only thing that you've really got to keep the blood pressure up and to add preload in order for that patient to stay alive. Just remember, it doesn't carry oxygen. I've said that before. Keep your patient warm. Cover them with a blanket. Keep the patient warm. Remember, if we cool them down, it interferes with hemostaxis. Okay? So keep them warm. Keep them warm. Keep them warm. Make sure your fluids, by the way, are above room temperature. Keep it warm. Keep it warm. Okay? There's very little effect. TXA can help a little bit. By the way, your cardiogenic shocks, you can give a vasopressor for those guys. Spinal shocks, obstructive shocks, again, IV fluids work pretty good. Same way with your distributive shocks. IV fluids actually work good in those cases, but so does your norepinephrine drip for a distributive shock. Your neurogenic shock, your septic shock. They work actually pretty good for that. So how do you manage these guys, again, for the shock? Remember, they're going to be anxious. They're going to be scared. Again, start the fluid replacement. But remember, it's a temporary fix, calm and reassuring. And remember that they've probably been through a very significant event, and try to reassure them that they're going to be okay. Now, again, to summarize this, number one, normal saline does not carry oxygen. It only keeps the blood pressure up for a minimal amount of time and actually probably causes a lot more damage than it does good. Okay? Keep them warm. All right? And a lot of the times we forget that. Keep them warm. All right? Last but not least is rapid transport. Get them. Remember that uncontrolled bleeding is a surgical emergency. We really need to get them to the doctor where they can fix the problem. All right. So, guys, remember, you're going to be doing a paper on this that's going to require you guys to say what it is that's going on with the patient as far as the effects. What happens to them? Stop and think about it. When oxygen is not being delivered, think about that whole citric acid cycle. And what's happening to that patient? It's making him worse. It makes the pH go down. Again, these are all things that causes increased blood clotting. It causes microclots. It causes damage to the cells and the tissues. So be thinking along that lines when you're talking about the hemorrhage control and how you can better get your patient out of that hemorrhagic or hypovolemic state or any type of shock state. There's different types of shocks and we treat it differently. All right, that does it for this, and I'll see you guys on the next one.